My name is Shelley Wiart, and I am a resident of Lloydminster, Alberta. I am a passionate advocate for an Alberta healthcare system that is accessible, equitable, and free of financial burden or other barriers. My focus is on saving Alberta's healthcare from privatization and supporting our healthcare professionals. I am a concerned mother advocating for the future of my children and all the families in Alberta that will be impacted by a two-tiered healthcare system. To learn more about protecting the future of Alberta families, save our healthcare, please subscribe to our social media. It is my intention through interviews with local family physicians to share unbiased information, promote active citizenship, and build community relationships between constituents and our rural physicians.
I'm English, I'm British, born in the north of England. I trained in Scotland. I became a family doctor in 2001. So I've been doing this for nearly 20 years. I came to Canada with my wife, who's also a family doctor, in 2014, and we've been here since then. I have a background of medical training. I used to organise doctors to be GPs, training for GPs, which is significantly different in the UK than it is in Canada. I also have a background of healthcare commissioning. I worked within our local healthcare economy, and we had a budget of £280 million, with which we commissioned both primary and secondary healthcare services and tertiary healthcare services for our population in a place called Rotherham in the north of England, which was a population of about 300,000 to 400,000 people. I think that there's a very easy statement to say, well, these rich family doctors or these rich doctors are earning, 11,000 doctors are earning $5.6 billion. Actually, with very little investigation, you could see that that's actually not the case, and that what that 5.6 or $5.4 billion that the government allocates for what it labels as physician remuneration is actually not that. It's actually providing facilities for healthcare to exist. Every doctor's office you walk into is paid for out of the money that doctor bills for seeing you. And on average, it's, depending on the specialty, on average, it's probably about 30% goes directly to overheads. So, for example, a lot of doctors have a worry about sharing what they earn. I don't think we should. I think ultimately, if governmental policy, I think we should be transparent. I have no problem. I billed in the region of $400,000 last year. My direct clinic costs, so running clinic, employing staff, paper, cleaning supplies, all of that kind of stuff, probably equated to about $100,000. I have professional expenses, so I have things like CMPA, which is my defence subs, and some of those are reimbursed, but I still have some out-of-pocket expenses. I have collegiate fees, so the College of Physicians and Surgeons of Alberta, I have an annual subscription to them of about $1,500. I'm a member of the Canadian College of Family Practitioners, which is a similar amount. I'm also a fellow of the Royal College of General Practitioners in the UK, which costs again about $1,000, $900, something like that. I have no funded pension, so I have a pension, which I pay for through my professional corporation, and I have no sick benefit or healthcare benefits. So I obviously have Blue Cross, which I also pay for out of that. So ultimately, what I take home a month is about $10,000. Which is a very good salary, and a salary that I totally acknowledges, far greater than the Albertan average, and I feel privileged to earn that amount of money. It is not $400,000 or $500,000. And that is the rhetoric that I feel is misleading, and I think is disingenuous. Ultimately, to give context to that income, I am responsible for my patients from 7 o'clock in the morning to 7 p.m. at night, 7 days a week. So I am effectively on call for a minimum of 96 hours per week. And then I also have ER call, and I probably do. We're better at the moment, but certainly when I started, we would do 1 or 2 a week, and that's a 24-hour on call. Okay, for emergencies, and our emergency department in Wainwright sees between 30 and 40 patients a day, and some of and we see everything. So hangnail to major trauma, heart attack to skin rash. You know how emergency rooms work. We're also responsible for, during that period of time, for all the patients in our on-call period out of hours, for our inpatients at the hospital, in the emergency, in the acute care setting, and the long-term care facility that we have. So, my average working week, or certainly my hours of responsibility, I'm probably responsible, maybe not seeing people face to face, but I'm probably responsible for 90 plus hours a week. Wow. Of being available. Okay. Face to face in my clinic is probably in the region of 30 hours of direct patient contact, not including the on-call, which tends to be pretty constant patient contact. And then obviously there's paperwork, there's ward rounds, there's dictation, there's insurance forms, there's coordination of patients' care, there's liaising with home care, there's fighting with governments. It's a busy life, and I enjoy it. I love it. I love what I do. I feel very privileged to do what I do. And I think one of the things that's affected me most is somebody coming along who doesn't understand what I do, who hasn't taken the time, on the face of it, has not taken the time to see what it is that I do for a living, and see the kind of level of healthcare I provide, and then assume that I'm not worth it. And frankly, that's one of the reasons I left the UK. Been there, done that, and got the T-shirt. I'm afraid this is not new political government rhetoric, not at all. This is a very familiar. Let's go. We're in a recession. Let's go after high paid state employees, because in this time of people losing their jobs, it's very easy to kind of say to people, well, yeah, you've lost your job, and look at that guy, he's earning hundreds of thousands of dollars, and that's his fault, which I think is a very sad and destructive rhetoric to use, and is unhelpful, because the fact of the matter is you then end up with unhappy, burnt out doctors who are more likely to make mistakes or more likely to leave. I've moved continents. I brought my family across a continent. You don't think I'm going to go to the next province? Mm-hmm. Why did I choose Alberta? Alberta gave me a good quality of life. But if that quality of life therefore becomes homogenized with other provinces, why wouldn't I go and experience somewhere else?
So you spoke with the MLA back in April, so Garth Rosewell, about what was happening with Alberta healthcare, and what kind of answers did you receive from him?
The predominant theory, the predominant subject for that was the changes to the billing structure, which actually the Albertan government did roll back. And that was primarily run from there's something called the CMGP, which is a complex modifier, which means that we can bill for a 15-minute appointment. I've done 10-minute appointments for most of my career in the UK, and it's not enough time. So having 15 minutes with a patient is important. Can I see people in a short period of time? Yes, absolutely. Yes. Can I do my job properly? No. I can deal with your problem. I can deal with your rash. What I can't ask you is, how are you? What's going on in your life? Do you have any other health concerns? Oh, look, I can see that we've got this outstanding issue. Let's deal with that as well. Equally, if somebody's presenting to me with a new onset of depression, 10 minutes ain't enough time to deal with that. If I've got a suspected cancer diagnosis or a proven cancer diagnosis, oh, hi, Dr. Turner, nice to see you. You've got cancer. Sorry, that's all the time I have. That's not a conversation that we have. So the government was suggesting that CMGP modifier should go. We felt very strongly that it shouldn't, particularly in rural settings, in the fact that there's a finite number of patients. If I'm all of a sudden being expected to see 50% more patients to maintain my income, and when I say maintain my income, maintain the viability of my business, is what I'm meaning by that, then I'm going to be seeing 50% more patients. There's not enough patients for that. So clinic practices would become non-viable. And this is, I suspect, what Dr. Nwadi was telling you about, is that, people would be the people who just lose out.
Yeah.
The problem that you have...
You had spoken about a doctor who had left Wainwright, and that was kind of the situation, was that, it wasn't viable for her to stay there. She had to go to the city because there's more people that she could potentially...
Dr. Colthurst, and I was very interested in Mr. Roswell's view on that, and I'm not sure he fully understood the situation. I know Dr. Colthurst very well. I've worked with him for 6 years, and whilst he did suggest that at some point in the future he was looking to maybe move towards the city, it certainly wasn't this year. So regardless of whether it's a new decision or it's hastened the decision, it has meant that Wainwright no longer has a family doctor. And again, Mr. Roswell's statement along the lines that, they've already filled that post. Well, unfortunately, I don't feel that's a strictly accurate representation of the situation. The doctor was coming anyway, but she's not a family doctor. She is a family doctor trained, but she is not opening a family clinic. She is having a specialist clinic, surgery, obstetrics, which is great. We need it. But the patients who are currently seeing Dr. Colthurst no longer have a family doctor. So there's 1,500 patients roughly who are now having to look for a family doctor. Now, we'll be able to soak up some of those, but I've no doubt that there will be some patients who, because of the threatened changes and the way that the posturing has unnerved a doctor to hit the trigger early, to leave early, without our ability as a town to do succession planning and to manage the transfer of care and recruit more doctors. So I feel that perhaps he's misunderstanding exactly the situation there, and I think that maybe there are some quite important nuances which he doesn't fairly represent.
Okay. It's good to know, because how can I fact check these things? Whatever a politician tells you, you could take at face value, I guess, because he is talking to people, but he's obviously missing some of the information that was vital to understanding what was happening. So I'm really interested to know, what happens when one of your colleagues leaves and there's 1,500 patients, and yes, you can take a few of them. You can't take all of them. What happens within the system? Do they just end up in the ER, or what happens?
Pretty much. Again, if one looks, there are various different claims that people make, and the thing about claims is a lot of them about perspective. And I'm sure as an Indigenous woman, you know a lot about the way that political perspective can change the rhetoric. And certainly, I'm not comparing this to Indigenous, but Indigenous affairs. But certainly, there's some comparators. Alberta is under-doctored. I don't think there's any doubt about that. And if you look at Canada overall, and you compare it to most European countries, the number of doctors per 100,000 population is probably low. And the place to look at is something called the OECD. And they have statistics which we're comparable with the States. But ultimately, we have 11,000 doctors, according to Mr. Oswell. And the population of Alberta is roughly 5 million, 5.5 million. So that is, how many patients should a family doctor have? If you talk about 2,000 roughly as being an average list, and that's a busy list, well, the maths doesn't stack up there. What's 5 million divided by 2,000? That's about 25,000 doctors, is it not? Is that my maths correct?
Yeah.
There's something that doesn't fit. And the other thing that we do have, and he's right in a lot. Whenever we're trying to kind of discuss with people, I think it's really important that the first place that we start is, and we should always start, is what do we agree on? Because I think in the most context, the majority of arguments and the disagreement is about one or two pieces of information, and overall, there's more agreement than disagreement. We all want to provide good healthcare to Albertans. That's what we want. We all want to make sure that we're being as efficient as we can and we're providing a cost-effective healthcare system, because the last thing that any of us want is private healthcare. I do not want an American system. I would not, frankly, work in an American system. I believe socialized healthcare is a human right. And I think the first thing that people should do when they come into a hospital is worry about their health, not their bank balance. But we do need to look at where doctors are being employed, and we do need to look at the type of doctors that we're doing. As a family doctor, I am the least paid of any doctor, virtually. Pediatricians and psychiatrists similarly, but their overheads are possibly slightly different. I can't comment on that, actually. I shouldn't comment on that. But am I worth half of a cardiologist? Am I worth a third of an ophthalmologist? And ultimately, when people leave medical school, bright-eyed and bushy-tailed, I vaguely remember it, they go, what did I enjoy as a student? And then there'll usually be a couple of things that they'll enjoy. And then they will say, okay, well, what are the implications to me? Okay. I enjoyed family medicine, but I'm not going to be paid very well, and I'm going to be on call a lot, particularly if I'm in rural medicine. Or I'll go and be a dermatologist. I really enjoyed being a dermatologist, and I'll have 9 to 5, and I'll earn twice as much. Well, what would you do? Those are the questions that we have, and in Alberta, if you have a PRAC ID number, you can set up shop wherever you want. So if you have a training in dermatology, you can set up, and draw work in. That's the nature of our system. So I think it's not unreasonable to say, right, how many dermatologists do we need? How many, and limit the number. I think that's sensible, because we don't want oversupply of one set of specialists and then an undersupply of another. We don't. That doesn't help any of us. It's not smart. And then I think the other thing we need to do is we need to say, what do we value people at? What is reasonable? And the fact of the matter is, if you want to encourage people to do an unpleasant job, you pay them more. On the most part, sorry, that's what it is. I love living and working in a rural community, but I could certainly understand it's not for everybody. When you're walking around Walmart and somebody comes up to you and, look at this rash, that's quite intrusive. And that will put a lot of people off. So quality of life is important.
So I guess the other thing I wanted to talk about was like the UK system, when you said that they did privatize some of it and they were cherry picking their patients. And I want you to explain that in layman's terms, because some people are in support of privatization, but they don't understand what the consequences of that are. And you are familiar with that system.
Yeah, very much so. And if you look at it, approximately, the NHS in the UK is huge. It is the fourth largest employer in the world. There's some crazy statistics about it. And the annual budget of it makes $5.4 billion look like chicken feed. But approximately about 10% of NHS budget goes on private providers, and some of it very successfully, and some of it not. Ultimately, what you have to acknowledge, and I speak as this as a commissioner as well, and we have commissioned private services. We did commission private providers to provide to the NHS. He's absolutely correct in saying that it is not strictly speaking private. Okay, it is commissioned by the Albertan Health Services to provide services for Alberta patients. So there's no payment to you or I when we go into one of these facilities. But these are not major facilities. Okay, so as an example, in the UK, if we look at things like hip replacements, there may well be facility to do the hip replacement, but what if it goes wrong? There's no intensive care unit there. There's no anaesthetist ITU service there. What if somebody has a heart attack on the table? There's no cardiologist or internist there. So these places have a lower threshold to look for, or historically, I mean, I'm not talking about, I can't make any comments about the proposed service in Edmonton, but what I can say is that potentially these services will look at patients and go, well, actually, you've had a history of heart attack or a stroke, or we're not going to do you because you're a higher anesthetic risk. Okay, you're more complicated. So we're going to take our younger patient, our fitter patient, with less risk of complications and less risk of side effects. So this does two things. This actually, therefore, takes those resources out of, because we pay in a fee-paying system, so that money will then leave the hospitals that were doing these operations. Mm-hmm. And on the most part, hospitals work knowing that some people are going to cost more than others. You know, I know for a fact that sometimes I will have a consult, which will be a relatively straightforward consult, and I will bill 15 minutes of my time. And I will have another consult, which I will still bill 15 minutes of my time, but it's a totally separate, complicated, you know, in-depth, multiple medical problems. You know, that's the nature of the game. We know that. Mm-hmm. So it withdraws money from other hospitals. The other thing it does, which can be a little bit Machiavellian in a way, is it can make these units look very successful, mm-hmm. because they have less side effects, they have less mortality or morbidity following these replacements, because they are picking the patients, selecting their patients. Whereas if you go into a large state-funded hospital, they'll do anybody, you know, because they have to. There's nobody else to do them. So when you are doing, when you are commissioning private healthcare providers, you have to be very, very careful. They have a contract, and they will stick to that contract for good or for ill. You know, there will be contracts in that we have the right to. I have seen contracts. We have the right to choose what patients we choose. You know, what patients we will treat, to refuse referrals based on our assessment. So when you're writing the contracts, unless you know what you're doing, mm-hmm. then these loopholes can be created. And ultimately, somebody is making money. Okay? It's a private provider. They have stakeholders. They have shareholders. They have people who are doing it not for the good of their own health. They're doing it for the good of their pockets. Okay, I have no problem with people providing an excellent service on taxpayers' dollar and making money out of it. But if it then has a knock-on effect to the rest of the healthcare economy, we need to kind of raise questions about that, and we need to, what's going on here?
So the other thing I wanted to ask you about is being a doctor in a pandemic. How is it for you? And, you're putting your personal self at risk when you go to work and it's a pandemic. And so I want to hear the inside perspective that you have on it, because I really appreciate all the family physicians that are putting themselves at risk. And I want the public to know what it's like.
I think ultimately I'm quite old and long in the tooth, and I think that sometimes our military forces go away and they get shot at. It's part of the job description. We face infectious diseases every day of our lives. This is another one. I've been through H1N1. We've been through. We have flu every year, numerous amount of cold viruses, non-COVID-19 coronaviruses that we see. I think it's certainly, this one's certainly very, very different. It's a challenge. I think, I've seen some poorly patients with COVID-19. I think it's just a different day. It's just a different day. It's.
I guess I was just trying to pull at the heartstrings of people being not only is the government attacking you right now, but then you have to go into work every day and have COVID-19 on your mind and potentially be infected.
Yeah, absolutely. But ultimately, we're here to do a job.
Yeah.
And COVID-19 is a new thing. It is absolutely challenging. I wouldn't be lying if I said no. Absolutely, I've laid at night worrying that I don't give my 4-year-old COVID-19. That I worry for my family. I have elderly relatives in the UK who I can't speak to, who I can't go and visit. All those bits that everybody else is feeling. I don't feel that I'm any different, from that perspective. COVID-19 is having huge effects on every single one of us and a part of the economy. Yes, there are challenges that we face, but ultimately a sick patient is a sick patient, and they need us to be professional. They need us to be calm. They need us to be reassuring, regardless of whether they're having a heart attack or whether they've got COVID-19. Yes, it does pose challenges. Of course it does. We had quite a big kind of cohort in Wainwright where we had some poorly patients. But it's what we do. It's what we do. It's part of the job, and you just need to get on with it. Unfortunately, everybody else is getting on with it. So does it help that the government's been confrontational with doctors? No, of course it doesn't.
I'm really interested in hearing what family physicians would like for their patients to do, or what kind of advocacy or call to action do you have for us, for patients?
I think that what patients can do is advocate for their doctors, is say that what we want to make sure of is that number one, awareness. Awareness is really important. Awareness that when they start talking about physician reimbursement, they're not talking about what doctors take home. They are talking about the money that is provided to run clinics. Okay, so if you're going to reduce doctors' reimbursement by 30%, you are reducing reimbursement to clinics by 30%. Okay, so that means Albertans who are employed by doctors may lose their jobs. It will mean that means that it might take longer for somebody to pick the phone up because there might not be as many people in the office anymore. It might be that new equipment isn't being bought as replaced as it can be. So I think being aware is number one. It's always nice to get support from patients, and patients saying, I think the government is being unfair, or I support you. That's always nice. And make noise, do what you're doing. Just, keep, we're not, as Albertans, this is what we want. We want to make sure that our health service works. We want to make sure that when I'm sick, that there is somebody there.